Hello again. So now the revision block starts, and I will talk you through the diagnostics and treatment of PJI, periprosthetic joint infections. So first, I would show you the reason for revisions in some registry data, then how you do the diagnostics prior to revision. In German, there's the saying, an unplanned revision is a planned disaster, so that you have an idea what you will do. Then the diagnostic algorithm for PJI, and then the treatment concepts that are currently available. So again, data from the Swedish registry, causes for revisions, and what you see in the course over time is that in the mid-90s, aseptic loosening because of the wear problem was the most significant reason for loosening. And over the time, infection got a more severe problem. And this is where we are now, and infections are still increasing. Over the time, now you see the time period directly after surgery, and you see within the first 7 years, infections are the most common cause for revision. Overall, it still is loosening, but in the first years, always think about infection. And this is something we already discussed in the first talk, that the outcome after primary surgery is really excellent. So after 10 years, you're facing 5% revisions. But with each revision, the revision rate increases tremendously. So after 2 revision surgeries, after 5 years, you're almost about 25% of the patients will have another surgery. And then the disaster continues, and we know after 5 surgeries, 50% of the patients will end up in an arthrodesis, and resection arthroplasty, or in an amputation. So take care and plan your revisions wisely. The diagnostics aren't always that simple, like in these cases. So this is why you have to have kind of an algorithm prepared. First, like always, do a medical history and a clinical examination. You should look at the range of motion, gait pattern, ask the patient to show with his finger where is the pain, because they often refer pain is in the hip, but it's in the back. Then you ask, is the pain under load or at rest? Were there any changes between pre-op and post-op? Was there a pain-free interval? So the pain started a couple of months after the surgery. All this gives you a little hint what could be the reason for the pain. And also the immediate post-operative course. Was the wound secreting? Were there any redness or antibiotics administered for a longer time? Clinical examination, so ceramic on ceramic. Doesn't look too bad, but now you have a look at the clinical examination. Professor Windhager talked about this before. Hope the sound is working. You heard it? Okay, so you get that this is annoying for the patient in all situations of daily living. What's also part of the medical history is what's really important to get this implant sticker record. Okay, you have to know what kind of implant the patient has inside, because there are special explantation sets, or there's some tricks we will show you in the next session for each specific implant, how you get it out, and otherwise you have to do an ETO or worse. Okay, and also the OR report could be of use. The X-rays, they're like the same ones like you do for primary. So you do an AP standing, AP of the hip, and lateral view. I think it's obvious what's wrong with this patient. So the cup is really has a high inclination, and this is also a quicking hip. Okay. When you look at the diagnostic, at the X-rays, you should be able to look for signs of loosening. So the margin is more than 2 mils. Osteolysis, also more than 2 mils. Migration of the implant, this is quite hard to see with normal x-rays, so you have to do an EPRA or RCA, and you look for console formation. For the stem, you describe this in the Gruen zones, and for the cup, the Dili-Charnley zones, okay, 1, 2, 3, and 1 to 7. This, for example, is a Zweimüller or L classic, as you have seen before. Obviously, you see this migration in loose cup, so it's a Bobrovsky 3B defect, migrated up and in. And what you also see in the zone 1 and 7, you see signs of loosening. When you know this stem, you know that this will be fixed, okay? You won't get it out. Although there are these loosening signs, they're typical for the stem, but this is anchoring in the diaphysis, okay? So be aware of what you're dealing with. Radiographs over time, like here you can see how this cup slowly migrates and gets steeper and steeper and steeper. And this is something we do not usually get, but it's on textbooks are the shoe they use, okay? Especially good for if you're looking for pelvic discontinuity. What we get for all our revisions, or at least all of them with a big bony defect of the acetabulum, we get a CT scan. And for reconstruction in selected cases, we would get a 3D print to plan the surgery with all the augments beforehand. MRI has a role in revision arthroplasty, but not the biggest role. If you're dealing with metallosis, so pseudotumor, or in PGI, if you are worried that the infect more or less goes up the psoas or something like this, MRI is a good option to detect this. And the primary rule, or the most important rule in diagnostic, is to rule out infection, okay? A painful THA should be considered to be infected until proved otherwise. This is the most important message. So because PGI is the most severe postoperative complication after THA, it has immense socioeconomic effect. The costs are more than 50,000 euros or even more, so 8 times higher than the primary implantation. We're increasing the antibiotic resistance, so we're facing bacteria we cannot treat. And you also have to be aware that the mortality rate after a PGI is higher than after a prostatacarcinoma or breast carcinoma. This is another study showing that after a periprosthetic joint infection, the mortality rate increases by 3.3% each year. The classification, the main difference is it acute and has an immature biofilm, so you can keep the implant, or is it chronic and you have a mature biofilm and the implant is lost and you have to change it, either 1 stage or 2 stage. The acute infection, we are talking about onset of symptoms 3 to 4 weeks, and this decreases more and more. Now the critical rate I will show you is more or less 1 week. So these are the early postoperative infections where you bring in the bacteria during the surgery, or a hematogenous spread where you have an infectious focus somewhere else, like a urinary tract infection or endocarditis. And here, Staph aureus is the most common cause. Others are Streptococcus, which are very difficult to treat in PGI, and gram-negative bacteria like E. coli, or even worse, Pseudomonas. So the acute infection, you have really, they're easy to diagnose. Joint pain, you have all the signs of inflammation, erythema, effusion, swelling, high local temperature, and the patient is really ill. Okay, he has maybe fever, sweats, and yeah, high fever. This is so of severe acute infection. So really pus running out of the wound. That's what we collected during the surgery. And on the other side, there are the chronic PGIs. So the onset of symptoms is after 3 to 4 weeks, typical within 3 to months to 3 years after the TGA. So either it's an inculation during the surgery, but with a low virulent bug, yes, or you have a spread from somewhere else later on. The symptoms are usually slowly progressing. Symptoms of non-specific, patients complain about nail pain, and as I said, vague pain, minimal effusion, local tenderness, and the temperature is slightly increased. And the patients doesn't feel well, but they're not really ill, like with an acute infection. This is our radiographs from a typical chronic infection. So you see how the bone already is affected. You see this loosening signs here. What are the risk factors for PGI? So some of them we have already discussed in sessions before, like anemia. Then there are some you can't modify, like diabetes or inflammatory arthritis, like rheumatoid arthritis or psoriasis arthritis. Male sex is a risk factor, and so on. Operative risk factors, if the patients need a blood transfusion, so you should avoid that. Prolonged operative time, so 90 to 120 minutes is here where the infection rate starts increasing, and simultaneous bilateral arthroplasty. Anybody is doing this of you? Selected cases or never? Never. Yeah. Okay. Yeah, you have to choose the patient wisely. And postoperative risk factors like discharge to a rehabilitation center. So these are usually the old patients that have a higher risk for infections, or those ones who stayed longer in hospital. For the diagnosis of acute PGI, as I said, it's easy. For the chronic PGI, you need more than one parameter. There's not the one who gives you the clue that this is infected or not infected. First of all, you should do the serum analysis. So CRP and white blood cell count are highly recommended. ESR is also in some of the diagnostic classification criteria. What are you usually getting, if I may ask? Same? CRP? Yeah, CRP is the best of those. The other ones also. Anybody getting D-dimer or fibrogen?
Yes.
Sometimes? Okay. What do you have to be aware? That a normal serum CRP doesn't rule out an infection. Okay? Sorry. So there's, especially low virulent terms, you can have normal CRP and white blood cell count. Okay? So you have to be aware. Yeah? Sorry? Procalcitonin. We don't routinely get it, only in selected cases. You get it? Yeah? In all the cases?
Not in all the cases, because it's harder to work it.
Yeah. So for serum analysis, you should get it. It can be the first indication for a PGI. They're cheap, easy accessible. You should be aware of the low specificity. So if the patient has any other infection, this also could cause an elevated CRP. 30% of the low-grade infections have a normal CRP, and as said, other conditions could cause an elevated CRP or white blood cell count levels. The next step should be a joint aspiration. This is how we do it, so every painful hip will be aspirated in our department. We do it under fluoroscopy to be sure that we touch the prosthesis, stereo conditions, and what we also do, we make a little skin incision to avoid inoculation of the skin flora. Okay, so you just take a sharp knife, cut the skin, and then you go through that with the needle. What we get here, so we do the microbiology with 14 days. This is also important of incubations. We do PCR. I don't know, you have access to PCR at home? Yes? You get it for all of the patients? Sometimes, okay. There's also the option for the BioFire PCR. You have it within 2 hours, but there are some problems with that because you do not catch Staph epidermidis, which is quite common in the infection. And then you look for the leukocyte count. Here's the critical number 3000 in all the classifications, no matter if EPCHIS or MRSIS. And the other thing is the polymorph nuclear neutrophils. Here's over 80% the critical mass. Okay, and alpha defensign, you use this one? Intro-op?
Yeah, rapid test.
Okay. For all the cases, it's quite expensive.
Again, for some cases, because the patient has to pay.
Ah, okay. Also an option. Yeah. Okay, so the microbiology is the gold standard to identify the pathogen. 14 days, we've discussed it. But for low virulence microorganisms, the detection rate is rather low. So up to 30%, even 50% in some studies, you cannot find the bug. Okay? Superficial swabs, we don't do this anymore. It's not recommended.
5 tissue samples.
Sorry?
5 tissue samples.
Yeah, we go through that. Now we are not in surgery yet. We're pre-op. Okay, what do you do with the aspirate? So, which germs are you facing? Staphylococcus epidermidis is the most common one, and then Staph aureus. Okay, so these two you should bear in mind. White blood cell count has a high sensitivity and specificity through all these studies, and also the PMNs with 80%, also high sensitivity and specificity. Somebody of you is doing this, so doing this urinary tract test, the leukocyte esterase. You're using that one. It's easy to use. You just have to do centrifugation of the fluid, but then you can use it. And also in some studies, they were quite sensitive and specific. For defensign, we have talked about it. It's good in some studies. You can either do this lateral flow test, which is like a corona test. Sensitivity and specificity is rather high, but it's expensive. So we only do it in selected cases. Now we're going to the intraoperative diagnostics. Here it's recommended to take 4 to 6 tissue samples at least and do a histopathologic analysis and also microbiology. Okay, so here's the Krenn classification. You should be familiar with type 2 and type 3 are the two with infection. And now there's a new approach, the CD15 score. This will be published shortly by Krenn in the next year, as he told us. Sonication, you're using this. Yeah, this is also kind of a game changer. So with ultrasound, you break the biofilm of the bacteria, and then the detection rate, even for low virulence microbes, is increasing tremendously. So as I said, there's not a single test with 100% accuracy. There are the 4 internationally used criteria, like the ICM, the MSIS, the Infectious Disease Society of America classification criteria, and these are the ones we are using mainly, the EPCHIS criteria published in 2021. They all have these little cards you can use, you can wear in your coat, so that you don't have to remember them by heart. We did a study, our department, where we compared all of these classification criteria, and we've seen that the EPCHIS criteria were the best one for detection of an infection. So to summarize this, you take the history, you do the clinical examination, you do the blood samples, and then you aspirate. You get white blood cell count, PMN, microbiology, the Lear test, and alpha defensine, if you would like to. And then intra-op tissue sampling for histology and microbiology, and additionally the sonication. And then you should have the diagnosis. Next generation sequencing, we are not using it, but that you have heard about it. This is the next thing that you do in direct DNA or RNA. So you look for that in the aspiration, and this really helps in the very culture negative infections. So they showed that with these methods you could do 100% identify the bug which has been formerly culture negative. So this will be coming, but we are not using it routinely. Any of you have access to this? When the patient pays? No? Good. And now we are going for the treatment. So the 3 treatments options there, 1-stage revision and 2-stage revision. What are you mainly using? Sorry? Bone scan? Yeah. Bone scan has only limited value anymore. Yeah, it's still part of the Aptschis criteria, like here, but only to rule it out. We not routinely get it anymore. Okay. So these are the 3 concepts. You have a preferred one? 2-stage?
It depends, because if it's a strong infection, we usually do 2-stage, but if it's a acute infection, we are going for the diet.
Yeah, very good answer. So specific indication for each concept, okay? This is published by the effort, so there are all the concepts, so the DARE concept. What they all have in common that you usually give at least 12 weeks of antibiotics. For the 2-stage exchange, there's this short interval with 2 weeks of spacer interval, or the traditional one, as we mainly use it, with 6 weeks of interval. So the DARE. DARE means debridement, antibiotics, irrigation, and implant retention. Okay? So you keep the implant, you do an aggressive debridement and synovectomy, you change all the mobile components. And there's also the discussion, what is a mobile component? For sure the head and the liner. If the liner is a ceramic liner, it's hard to get out. What do? Change the cup? Yeah, you keep it. And what about an uncemented stem and you do it there after 1 week? Is it fixed or not? So you change it? You keep it? So we would get it out. It's not integrated, so we would get it out. Okay?
Remove the stem.
We remove the stem.
Okay.
Yeah, but we have a quite aggressive approach to that. Okay?
What is the cutoff then? So 1 week you change?
I'll come to that in a second. Yeah, good. This is the most important thing about the DARE. Okay, and then you do the irrigation, 6 to 10 liters. The advantages are obvious. It's less invasive, and you can keep the implant.
Are you using only ringgit for irrigation?
No, we do positive lavage and also chlorhexidine.
Chlorhexidine?
Sorry?
Chlorhexidine?
Yeah.
What kind of percentage?
I don't know. The one that provided. But you also could use polyhexidine. Yeah. There's an ongoing discussion which is best. The German Association for Arthroplasty will publish a pocket card on this in this year, so maybe this will be easier then, at least for me, which one to use.
Do you wash the patients with chlorhexidine before the surgery?
And no, we are using Isodine.
Yeah, with
Yeah.
some antibiotic. I mean, not on the surgical side, but when you accept them to the department, you do washing of.
You mean the decolonization?
Yeah.
Yeah, we do that 3 days before. Yeah. So the preconditions are that obviously the implant is stable. And now we are going to that. The critical time, is 1 to 3 weeks, okay? After that, the success rate of a DARE will decrease tremendously. And this is a review of cohort studies. And here, the failure rate before 7 days is 28%, and after 7 days is 48%. Okay, this is why we are that aggressive. After 1 week, we would do a one-stage revision, even in the early postoperative phase. Okay, so this is an important number for the 7 days. What else should you look at? Stable protection, stable prosthesis, short duration, and acute postoperative PGI. The patient should not be immune compromised. Okay, if it's a sick patient, it's safer to go for a one-stage or two-stage revision. Obese patients have a higher treatment failure, 58% versus 37% one study have shown. So in these, also go for a one-stage or two-stage revision. And nicotine use is also something you should be aware of. 12-fold risk of reinfection after a dare in smokers. So now we're heading for the other big concept, the one-stage revision. So basically what this is 2 surgeries in one anesthesia. So you do the explantation of the implant, you do an aggressive debridement, and then you irrigate, and then you use polyhexidine or chlorhexidine, put it in the wound, and then you make a temporary wound closure. Then the entire team rescrubs, also the nurse. The patient is retrapped and retraped again, new instruments, and then you do the replantation. The endoclinic in Europe, maybe or worldwide, the center with the most experience in one-stage revision, always goes for cemented fixation. We don't do this, but you should have heard it. Okay. What are the outcomes? So plenty of studies over all the years, and the reinfection rate after one stage is from 0 to 26%. That's what the studies claim. Never trust a study with 0% reinfection rate, okay? There are now coming registry data coming out from Germany, which are showing that the reinfection rate is higher than all the studies are claiming. It's about 30% after 1 year, also in the big centers. So reinfection is the main problem, and it's underestimated in most of the studies. Here again, patient selection is key. There are the recommendations of the different societies. I'll show you ours, which go along with the effort concept. So you need to know the bug, okay? You have to treat it exactly with the right antibiotics. It must not be a difficult to treat bug. The host should be good bone stock, good soft tissue, no sepsis, no fistula, and not in multiple revisions. This is when you have a patient like this, we go for a one stage, all the other ones go for a two stage. Okay, it's highly discussed in all the meetings, but this is our approach, and I have to admit we are aggressive, but we are attached at a referral center, so we see a lot of sick patients, and we are strong on the two-stage revision. So two-stage revision, you all know the concept: explantation, spacer implantation, 6 weeks or 2 weeks, then replantation, and in total 12 weeks antibiotics. As I said before, streptococcus, for example, you have to give, there's a study now coming out, 12 months of antibiotics, because these are really hard to treat. The indications, for us, it's still the gold standard in the treatment. We don't see any contraindications, so you can use it with an unstable prosthesis, chronic infection, immune-compromised host, major bone defects, bad soft tissue. You can also do flaps in a two-stage. We can use it in difficult-to-treat germs, and we can use it in patients with sepsis. Okay? What we would do in a patient with a really high CRP, 30, or maybe in some cases 300, depends what margins you're using. We would first do a drainage, just a drainage, wait until the patient is better, and then perform the explantation. Okay. So for the spacers, these are the commercially available antibiotics you could use. So for example, with gentamicin and vancomycin. And here are the recommendations from the effort to add antibiotics. If you don't know the bug, add 2 grams of vancomycin. So this is 1 pack of cement. this is what we do. Yeah, you can compromise the stability of the cement during the spacer interval because you get it out anyway. Okay, and there are recommendations for all the different terms in this publication. This is the spacers that are available, so Steinmann pin or intramedullary nail, custom mold or this pre-molded ones. This was the stage 1. It's no longer available, unfortunately. What are you using for spacers? Articulating spacer? And commercially available, or you do them on your own?
No, commercial.
Okay. You do it on your own? Yeah. Okay. So Charité published them just doing a gallstone situation and then do the replantation after 6 weeks. Works in their hand. We are doing, we mold them by ourselves. I'll show you how we do it. So what we do a poorly cemented stem, bipolar head, and we do an additional cement layer. I hope you can see it in the acetabulum. Okay, so this was a patient with a severe wear. You can see the decentralization of the head and the massive osteolysis. Then spacer interval. You know what this is? Stimulant, yeah. So calcium sulfate. And then replantation with a modular stem. We also would use it in big defects. So this patient, also young, rheumatoid arthritis, had an infection with a Staph epidermidis, so low-grade infection, working for a long time. This loose cup, big defect. And here we would use also cement to fill it. And behind it we would use stimulant also inside of the stem. And then the articular spacer. Here, the reconstruction, we did a 3D print. You see this huge defect. It migrated medial, but also the posterior column was missing. Here the intraoperative picture. There is the leg, here the head. And this is the reconstruction. So with a buttress augment, 2 other augments, cup inside, and then a dual mobility cup.
Excuse me, which approach?
This was the anterior lateral approach. Easier from a posterior approach. But the patient was young and had surgery from the lateral approach. That's why we used the old scar and modified it to an anterolateral approach. Another case with a huge defect, also infected. What we did here, also we did, I'll show you on the CT scan. So we tried to do an impaction grafting. We kept her in the space interval for 4 months so that this had a chance to osteointegrate. Here in the CT scan, you can see it. So this is the structure, the autograft. No, the autograft, so the dead bone with additional vancomycin, the cement layer, and here you see how it's integrated. So this was stable, and this is the reconstruction. So up there is the bone. Then here 2 augments, another cup, cage, and then cemented in a bipolar cup. For huge femoral defects, we tend to use this implant as a spacer. So this is like a long Chanli, so a stem. We cover it with cement, also cement in the acetabulum. And this one is waiting for the reconstruction. And in this case, here the bone is completely infected with osteomyelitis. So we had no chance of keeping that when we did a resection of the proximal femur, also a stem with an additional rod, and then reconstruction for megaprosthesis. The outcomes for the 2-stage revision, revision rates 0 to 12%. As I told you, this is underestimated. Reinfection rates also at our department are higher. So what is better, 1-stage or 2-stage? Usually all the data we have are not from randomized controlled trials. It's always retrospective data, meta-analysis available. And here they claim that the reinfection rate is the same. But as it's retrospective data, there's a selection bias. The more challenging cases are treated with two-stage, they have the higher reinfection rate, is our opinion. The downsides of the two-stage, higher costs, so 50% more expensive. It's more burdensome for the patient to live in a spacer interval, to have no joint they can rely on, and the rehabilitation is significantly slower. One stage, it is important to choose the patients wisely. This is the only randomized controlled study available, the INFORM study, published 2022. So 15 centers from UK, 3 from Sweden, and they did compared one-stage and two-stage revision. And here you see that the functional outcome, the WOMAT score, is better during the first year after one stage than after two stage. The reinfection rate was the same, and the costs were lower for one stage revision. This is the algorithm we are more or less using. So you have acute PGI, to summarize this. You have a good bone stock, stable prosthesis, not a difficult to treat term, and symptoms are below 1 week. We would go for a DARE. Otherwise, you have to exchange the prosthesis, either one stage or two stage, depending on the causes we've discussed before. So this is something more or less new, Stimulan. You all know it, so calcium sulfan beads you can add to, as well as one stage as a two-stage revision. And here the critical thing that makes it better than the spacers alone is that you have a high value of antibiotics in your wound for a couple of days, while the spacer, after 48 hours, you don't have any vancomycin left. Okay, so these are the concentrations after putting it in. Here again, you see it. So this yellow one, the blue one is the spacer alone. The black one is the spacer alone. And after within hours, the values decrease. And here the red one is spacer and Stimulan together, and you see how the concentration levels stay high. Okay. What we would have worried about is that we have a third a wear problem, third body wear, and there are also studies showing that this is the positive control, where you see some wear, and here are the lines for calcium sulfate and the negative control group, and you don't have any wear problem. Okay, so it's safe to use it even in a one-stage revision or when you put in your definitive implant. What are the downsides or the complication? The wound drainage. So you have to be very meticulous with your wound closure. Hypercalcemia. We had one patient who had this. She developed a pancreatitis and got to intensive care and almost died after that. So you have to be aware. Don't use too high dosages. So max is 20 ccm, okay, not more. And heterotrophic ossifications, you also see this within the first year. But after all, they're simple and rapid to apply. You get high local antibiotic levels over a longer time period. You have a synergistic effect with the cement spacer. You have a local antibiotic during the replantation. You can add any antibiotics that the company says, okay? So you even can use like dalbavancin or something like this, very fancy and very expensive, but you could add it to the beads. We haven't done this, but there are protocols how to mix it during the surgery. And you have no third body wear. It's expensive, so it's about 490 euros for a small package, 800 euros for a large package, and the complications we've already discussed. Here you see how easy it's to apply. So you just basically put it in when you're done with your surgery. And this is how it looks. And within weeks, you won't see the beads anymore. This is another case. 7 revisions, pelvic discontinuity, posterior column is missing completely. It's the planning on the 3D printed model, intraoperative situs, and here you see the stimulant beats again. So let me summarize. The diagnosis can be challenging, so I highly recommend using an algorithm. There's a trend there only in selected patients. There's a trend towards one stage. We are now pushing the indications and you see the data coming out. But in our hands, two-stage revision is still the gold standard. For bigger defects and multiple revision, two-stage is still the best treatment options, and new local antibiotics show promising results so far. So thank you very much.